Well, hello, and welcome to this lesson on assessment of the nervous system. This is Mrs. White, and we'll get started. All right, first and foremost, the nervous system is actually divided into two systems. We have the central nervous system and the peripheral nervous system. The central nervous system consists of the brain, the spinal cord, and cranial nerves 1 and 2. And the peripheral nervous system then picks up at cranial nerves 3 to 12, the spinal nerves, and then the peripheral autonomic nervous system. All right, so there are two types of cells that we need to be concerned with. The first is a neuron. It is the functional unit of the nervous system, and its purpose is to initiate, receive, and process messages about events both inside and outside of the body. Three characteristics of a neuron are that it's got excitability, conductivity, and influenceability. Now, axons of the neuron are covered in the myelin sheath, and that sheath allows the fast hopping of the message from the nerve to the next nerve. Now, glial cells actually provide support, nourishment, and protection to the neurons. Basically, there's microglia, those are macrophages, and the macroglial cells actually form the blood-brain barrier. In the past, we did not know that there was nerve regeneration. At least the science was a little bit too much in its infancy. But we do know that damaged nerve cells do try to grow back. It's a slow process. Peripheral is more successful than central. And basically, again, neurons were once considered non-mitotic, that they didn't divide and they didn't grow, but they can. And this picture I have here, that is Christopher Reeves, who sustained a traumatic injury, a spinal cord injury, following being thrown from a horse. And if you do any sort of searching for his name before he died, he was engaged in a lot of research and studies to try and get some form of nerve use back. So it's just interesting. All right, so how is the nerve impulse sent? Basically, by neurotransmitters. Neurotransmitters are chemicals that affect the transmission of impulses across the synaptic cleft. They can be either excitatory or inhibitory. So they're either going to cause an increase or a decrease. So remember, having that myelin sheath speeds up conduction of the nerve impulse. So that's how we start to see some disorders with the loss of the myelin sheath and the slowing of the nerve conduction. All right, so the spinal cord is part of the central nervous system, and basically it's the continuation of the brainstem that exits the cranial cavity from the foramen magnum. And there are ascending and descending tracks. So the ascending tracks carry messages up, things like touch, pressure, vibration, position sense, and the descending tracks carry impulses responsible for muscle movement. And that voluntary movement is called pyramidal. So when you start to thinking about extrapyramidal symptoms, things like that as a side effect to medications, this is what they're talking about. And here I do have a picture of the spinal pathways, or the tracks, and you can see what part of the spinal column innervates the different parts of the body. And so some of us that have back injuries or other injuries, you can see where the loss of function is by looking at where the spinal pathway is in the tract. So, for example, I know I have a problem with C7 and C8, so I often have problems all the way down my arm. And I also have L5S1, so I have some trouble with the that sort of area down here as well. So you may find something similar in your signs and symptoms. All right, so let's talk about the lower and upper motor neurons. There are several differences between the upper motor neurons and the lowers. First of all, the upper is a motor neuron that originates from the motor region of the cerebral cortex or from the brainstem. And it's located near the central nervous system, and it transmits the nerve impulses from the brain to the synapses of the lower motor neurons. The lower motor neurons transmit the nerve impulses that they've received from the upper motor neurons to the effector muscles. So it's located near the muscles. And so they form the synapses with muscles. And these are found in the brainstem and the spinal cord. So the difference that we'll see if a person has a problem with their upper motor neurons versus the lower is if they have a lesion in the upper, it's more of a paralysis effect rather than muscles. And so we'll look more like at spasticity, and the muscles are hypertonic, versus lower motor neuron lesions. It's more pronounced wasting, and the muscles are hypotonic or flaccid. So it's the difference between something being spastic or flaccid. So the disorders that we could talk about under some of the other lectures, the signs and symptoms that we see are based on whether they're impacting the upper motor neurons or the lower. All right, so now let's get into the brain. There are three main components of the brain. We have the cerebrum, the basal ganglia, and then the thalamus and hypothalamus. So we'll talk about the cerebrum here. We do have right and left cerebral hemispheres. There are four lobes. We have the frontal lobe, which controls higher cognitive function, memory, voluntary eye movements, voluntary motor movement, and speech. So Broca area is in the frontal lobe. The temporal controls our somatics, visual and auditory processing, and we also have the Wernicke receptive speech area. Parietal lobe gives us a spatial orientation and has our sensory cortex there. And then the occipital is responsible for vision. So any problem with any particular area of the brain is what we're going to see in signs and symptoms. Now, the basal ganglia controls voluntary movement, learning, emotional response, and then also our automatic skeletal muscle movements. All right, so thalamus and hypothalamus is what we discussed under the endocrine lectures. So if you have any questions or concerns about what you see on this, I would encourage you to go back to endocrine and look at thalamus versus the hypothalamus, and then also note the limbic system in here, concerned with emotion and aggression. All right, so the brainstem is made up of the midbrain, the pons, the medulla, the reticular formation, basically relays sensory information and also controls vasomotor and respiratory activity. So as nurses, if we have a concern about the brainstem, then we need to be very, very concerned about the respiratory center and respiratory status of the patient. The cerebellum sits below the occipital lobe. It controls voluntary movement. It also gives us trunk stability and equilibrium. And when we want to test cerebellar function, this is where we have the person walking, checking their gait, their arms swing through, basically checking their position sense. All right. The ventricles, we have four connected fluid-filled cavities, and they are filled with cerebral spinal fluid. So we do make about 20 to 30 mLs of cerebral spinal fluid every hour. Cerebrospinal fluid is meant to cushion the brain and spinal cord, to carry nutrients, and medically it's important to us because it allows us to monitor pressures and then also sample the central nervous system. Okay, as we move along, we have the peripheral nervous system next. So the spinal nerves, these are considered motor sensory nerves. Dermatome is the term used for the area around the skin that's innervated by these sensory fibers. And myotome is the same as dermatome, except it's the muscle group. And our cranial nerves, they can be motor, sensory, or both. Uh, There's various mnemonics that you can use to remind yourself of the cranial nerves, and there's just a couple different slides in here on them. I did provide a handout in class on assessment of the cranial nerves, but it's important to know what they do because what we're going to see in our patients could be due to a cranial nerve lesion or problem with the cranial nerve as a result of pressure or an injury. All right, so here is our autonomic nervous system. It is fight or flight on the sympathetic, which is norepinephrine, acetylcholine, and we talk about fight or flight a lot under shock. So if you need to go review the shock lectures, they are available for you. And the parasympathetic is sort of the antidote to the autonomic. It is our rest and digest. And so we have a constant interplay between the different parts of the autonomic nervous system. So that is what you have here. Now, blood supply to the brain comes from the internal carotid arteries and the vertebral arteries. And you might just pop a little back and forth, so that you can see the different vessels and how they actually go into the brain. But I will sit in here for the moment. So the ICA, or internal carotid artery, supplies blood to the middle portions of the cerebrum. The basal artery, or basilar artery, supplies the temporal lobe, the occipital lobe, cerebellum, and the brainstem. And the major branch of the basilar artery is called the circle of Willis. And the circle of Willis joins the basilar and the internal carotid together. So this is the major brain circulation, right? Venous blood drains through the sinuses, which then drain into the two jugular veins to leave the brain. The blood-brain barrier protects the brain matter while allowing nutrients to enter. This is a major consideration for medications, and the reason why we have difficulty with certain medications in treating people in their central nervous system. Also on the line of protection, we have the meninges, which is the outermost layer of the brain, the arachnoid space, which is a fragile middle layer, and then the subarachnoid space, which lies around the arachnoid and the pia mater, which is filled with cerebral spinal fluid, and then the pia mater, which is the vascular inner layer. So those are the three layers of the brain. As far as the skull, we have 8 cranial bones and 14 facial bones, and the foramen magnum is the only major space that we have for expansion of brain contents with increased ICP. And under the spinal column, we do have 33 vertebrae. There's 7 cervical, 12 thoracic, 5 lumbar, and 5 fused sacral. So gerontologic considerations that we need to worry about is we have widened ventricles as we're older, brain size and weight decrease, cerebrospinal fluid production decreases, there's myelin degeneration, which causes decreased nerve conduction. The patient will often have increased orthostasis, decreased ability to deal with temperature extremes, some memory changes, and then some sensory changes which affect balance and coordination. All right, so as we move down to the subjective assessment, we're going to get a lot of some of our assessment right in the health history. And some things you need to ask yourself are, is this person a reliable historian? What's their level of consciousness? Are they oriented? Any history of present illness, especially progression of an illness? Medications, especially those that have an effect on the central or peripheral nervous system? Any substances used? How they participate in their ADLs? Any nutritional deficiencies, because those can affect the central nervous system? Bowel and bladder control, falls, insight into their illness, and their language, their use of it, both expressive and receptive. In our physical examination, we want to look at their general appearance, including their level of consciousness, their motor activity, their posture, hygiene, facial expression, orientation. We might be able to do a mini mental status examination, and the one we would use for delirium is the CAM, so CAM assessment. We look at their mood and affect. Are they agitated, anger, depressed? Are they euphoric? And is that a suitable sort of emotion that they're showing for what's going on? We look at their cranial nerve function. So cranial nerve 1 is olfactory. So anosmia is the loss of sense and smell, maybe an early sign of Alzheimer's, dementia, or Parkinson's. Basically, we ask the patient to close the nostril and identify easy smells. The optic is the second nerve. It's the peripheral field, so we'll use the Snellen chart. And then we have different forms of visual field deficits, whether it's hemenopsia, quadrantopsia, or bitemporal hemenopsia. If those sound like concepts you're not familiar with, I want you to go and look at what they are. Cranial nerve 3 is oculomotor. That we test this with the 6 cardinal positions, and we look for pupillary constriction and accommodation. So, and the question is somebody Pearl or Pearla? So remember, unconscious, we cannot assess accommodation. Trochlear, we can assess with cranial nerve 3. Trigeminal is facial sensation. Abducens is cranial nerve 6. Cranial nerve 7 is facial. We move along to vestibular cochlear, glossopharyngeal. So now we're starting to have different innervations. We start to have problems with the cranial nerves 9 and 10. We'd be very concerned about the patient's ability to swallow. Then you have your accessory cranial nerve 11 and hypoglossal, which is cranial nerve 12. So again, I gave you a handout with all of the cranial nerves and how to assess them. So motor function, we look at strength. We actually have to test the patient's ability to push and pull against resistance. Their muscle tone, whether they have flaccidity or spasticity, so hypotonia versus hypertonia, myoclonus, which is a spasm. All right, so cerebellar function. Again, we're going to test their posture, their gait, looking at arms swing through. We can test cerebellar function by having the patient rub the foot with the heel and the finger to nose test. So you'll see this often in DWI stops. Their balance and coordination is affected and impaired by alcohol, so they make them touch their finger out and then back to their nose. So this is exactly what they're testing. Sensory function, we do light, touch, temperature, and pain. Their positioning sense, so like the Romberg test. So the concern that a lot of people have when testing sensory is you might say to somebody, oh, can you feel this wisp of cotton, or can you feel this? And I don't want you to lead the patient with your assessments. Make sure that you don't tell them what you're going to touch them with. It should be soft or sharp, depending, but don't tell them because then that clues them in. You want them to tell you what it is. Okay, our reflexes are graded 0 to 5, and the reflexes that you need to know about are the biceps, the triceps, the brachioradialis, patellar, and Achilles tendon. Most commonly tested for us are the biceps and patellar, because that's the ones we're most familiar with, but a neurologist will indeed check every single one of them. All right, so cerebral spinal fluid analysis. Let's talk about normal. So normal is that it would be clear, colorless, odorless, without red blood cells, small amount of protein, and the sugar can also tell us a little bit about what's going on as well. There's some sugar in it. So the procedure is that we're going in through L3 or 4 or L4 to 5. It is absolutely contraindicated in increased intracranial pressure due to the risk of brain herniation. So pre-procedure, we want to check vital signs, baseline neuro assessment, looking for any signs and symptoms of increased intracranial pressure. We look at their coag studies to look for the possibility of a hematoma formation, do some patient teaching on what to expect, have them void. They might need some analgesia, but however, they don't generally need actual anesthesia. We place them in a sideline lateral recumbent position. And post-procedure, we're going to monitor their neurostatus and vital signs, monitor for a headache, keep pressure on in the pressure dressing, keep them reclined or flat, monitor and teach the signs of neural problems, encourage fluids, and pain control. All right, so just a couple more things to look at. Some of the testing we can do, the cerebral angiogram. So we can do sometimes like CTAs, which is a CT scan, but to see the actual vessels at the time of, if we could do an angiogram, basically that's the same process of any angiogram, going through a femoral artery, threading up and inserting the dye and looking at that. So if that's the case, then now we have a femoral artery punctured. So the risk for bleeding is very high afterwards. So you're going to go ahead and keep pressure dressing, assess the site, and then monitor for arterial compromise distal to the site. So from that leg down. Here's a CT and here's an MRI. CT is pretty much down and dirty, will show us areas of infarction, but not as sensitive as an MRI. But in emergency situations, CT is preferred. MRI might be able to show smaller lesions. All right, so let's talk about these studies for a brief moment. The EEG is what measures brainwave activity. We use that to monitor somebody in a coma, to check for brain death, and also to check for seizures. Electromyography is conduction of muscles. So that's a completely different, not to be confused with EEG, but it checks out the innervation of the muscles. We might use nerve conduction studies along with electromyography to tell the difference between a nerve disorder and a muscle disorder. And then evoked potentials is basically when we provide a stimulus and see if we can evoke some sort of a response, like putting flashing lights and seeing if it evokes a seizure response. All right, so as we go on down, so ultrasound, if somebody is having some neurological changes, sometimes double vision, things like that, we would do a carotid artery scan looking for some narrowing of the arteries, which could cause those issues. You can do a transcranial Doppler. Of course, there's limitations based on the thickness of the skull. And then biopsies can be done under ultrasound. All right, so let's look at a couple of questions here. Question number 1, nurse is caring for a patient admitted after a head injury. So when would the nurse obtain most of the data related to the patient's mental status? So what do you guys think? You can pause, but I'm going to click on the next. It's during the nursing health history. And if you don't have somebody that's able to give you information, like if the patient can't, then you might want to look to somebody that knows them well. All right, question 2, caring for a patient who has a spinothalamic tract lesion. So what assessment finding would the nurse expect? All right, it is loss of peripheral sensitivity to pain. The spinothalamic tracts are responsible for sensations of vague touch, pain, and temperature. So a lesion could result in loss of peripheral sensitivity. All right, and the last question, how should we assess cranial nerves 3, 4, and 6? All right, the answer is to test the patient's eye movements. So the oculomotor, trochlear, and abducens help to move these eyes. They can be tested by instructing the patient to follow the nurse's finger as it moves both horizontally and vertically. If the eyes move together, that's considered conjugate gaze. Cranial nerves 3, 4, and 6 are intact. Option A, which is checking the gag reflex, is for the facial nerve. Option C is hypoglossal, and option D is number 11, or glossopharyngeal and vagus. All right, so that's that. Thanks a lot for following along. If you'd like to, give me a like and a follow, and I would appreciate that greatly. And thank you so much.